Welcome to an IAPMD professional community webinar. Our monthly clinical practice webinars are led by experts in the field. Today's clinical practice session is led by Dr. Hannah Short, a GP and an accredited specialist in menopause and premenstrual disorders in the East of England.
So thank you. So as Laura said, I'm a GP. I'm based in the UK, and I've also done further training in menopause and premenstrual disorders. It's a special interest of mine, and I'm also kind of a member of the clinical advisory board for IAPMD. I've also done further training in lifestyle medicine and nutrition, and this is an area that interests me as well. These are my declarations. Okay. So if I didn't have sex organs, I wouldn't waver on the brink of nervous emotion and tears all the time. And that was the poet Sylvia Plath who said this. She wrote this in her diary when she was around 18 years of age, and she'd obviously already linked her change in emotions on a monthly basis to her cycle. Sadly, Sylvia Plath took her life when she was around 30. And just prior to her death, she'd arranged to see Dr. Katerina Dalton, who was a pioneer in the field of premenstrual syndrome and premenstrual disorders. She's the one who really started putting it on the map. And so Sylvia had obviously reached out to her and arranged to see her, but sadly, it was too late for Sylvia. We can't say definitively whether Sylvia suffered with PMDD or PMS, but I think it's been theorised that could definitely played a part in the mental struggles that she had during her young life. And I just think this quote is quite powerful, and it was written by somebody so young a long time ago now. I wanted to mention Katerina Dalton because, as I said, she's somebody who really put premenstrual disorders on the map, and people came to see her from all over the UK. I think people contacted her from around the world because nobody was really taking this condition or this group of conditions seriously. And although she was a big proponent of progestogen therapy, which is a whole other thing we're not going to get into now because there isn't much good evidence for that, she obviously did listen to these patients and tried to help. And at that time, she used to give some lifestyle medicine advice. So obviously it wasn't called that then, but she would often send people information about dietary changes and habits that might help them whilst they waited to see her. And more often than not, especially with the more milder forms of premenstrual disorder, people would cancel because they said actually a lot of these changes had really helped, which I think is kind of quite interesting. First of all, I just wanted to, I know we've got a group of people here and knowledge levels will be different, but just having a little look at the normal menstrual cycle. So if you're a female or you're assigned female at birth, born with ovaries, you've evolved really to have a menstrual cycle, and part of that is that you would have regular fluctuations in your hormones as demonstrated here. This is natural, it's expected, it's normal, and that's one of the key things really when it comes to premenstrual disorders. It's not really an abnormality with the hormones per se, it's more to do with the brain's response. And anybody who has periods may well be aware that their mood, energy levels, things like that change throughout the month. And again, there's nothing wrong with that. That's just part of being a biological being and maybe being a bit more in tune with your body. Most women will notice that their energy increases in the follicular phase just after the period. Mood tends to be a little bit more positive until ovulation. And around ovulation, there may be an increased sex drive, increased appetite. Things like that make sense when you're looking at it from an evolutionary perspective. And then after ovulation, the estrogen levels start to dip, and the corpus luteum, which is left after the egg has been released, will start producing progesterone. And this is this one here that starts building up. So in people without hormone sensitivity or premenstrual disorder, they may still be aware of subtle changes and feeling maybe a little bit more mellow, a little bit calmer, a little bit more sleepy, or sometimes it can tip over into feeling slightly kind of lower mood, a little bit more brain fog, but it shouldn't be impacting their quality of life. And some of this is just normal physiological changes and being aware that that there are shifts in the hormones which affect our mood and our bodies as well. Just Having a quick look at the three main types of premenstrual disorders. We've got premenstrual syndrome, which is a spectrum of physical and mood-related symptoms present in the luteal phase of the menstrual cycle, so the second part following ovulation. And this is believed to affect 20 to 40% of women and AFAB individuals. And it's hard actually to get a definitive figure, because when people do surveys, when the research is being conducted, people might define these in different ways. The fact is there are over 150 recognised symptoms of premenstrual syndrome. And we'll talk a little bit more about symptoms further on, but because we've got estrogen and progesterone receptors throughout our body, it's not surprising that many people might identify with that. Okay. Premenstrual exacerbation is the worsening of a pre-existing physical or psychiatric condition in the luteal phase of the menstrual cycle. So this isn't actually caused by the changing hormones, but it's just that the fact that the hormones are changing in terms of their levels and then dropping off again before menstruation does have an impact on other things. As I said, we've got receptors throughout our body. So there's something called catamenial epilepsy, which means that people struggling with that may be more likely to have more seizures in the second part of the menstrual cycle. A lot of people struggle with migraine as estrogen levels fall away. And then psychiatric manifestations can worsen. So if you already struggle with low mood, that may become more pronounced in that second part of the menstrual cycle. The same with intrusive thoughts and behaviours around OCD. The incidence of this is unknown because there have not been many good research studies to date. It's something that we need to be more aware of, because it can be quite hard to differentiate what's going on. PMDD, premenstrual dysphoric disorder, is really the most severe form of premenstrual disorder, and we differentiate it from PMS in that it has a much more significant impact on quality of life. So from my point of view as a GP, if somebody comes to see me in surgery and they're struggling a little bit, say with bloating, maybe feeling a little bit tearful and things like that in the lead up to their period, but they're managing to go to school or work, they're not cancelling social engagements, they're much more likely to fall into the PMS camp. If it's PMDD, symptoms may be so significant that you're unable to go to work, make irrational decisions. You may want to leave your partner, quit your job, may not actually be able to work, may not be able to physically do anything in the second part of the cycle. And this is something we all need to be aware of, because it's thought to affect around 5 to 8% of women and AFAB individuals, which is actually quite a large number of people. And sadly, 1 in 3 sufferers are thought to have attempted suicide during a crisis. So what are the symptoms? As I said, there are numerous symptoms, but if we're going to talk about the more severe form of premenstrual disorder, say PMDD, it's predominantly the psychological and the emotional symptoms that are the main issue. So more than just feeling low mood, there may be extreme sadness and despair, suicidal thoughts, so feeling severely wound up, tense, irritated, anxious, feeling out of control, severe lack of motivation, extreme fatigue, panic attacks. There can also be some, strong physical symptoms such as severe, food cravings or hypersomnia, not sleeping more than you normally would, or paradoxically could be insomnia. And then the physical symptoms can coexist as well. But often what we do see with PMDD is that the psychological and emotional symptoms are the ones that are the most difficult to manage. Okay. So what's going on? Again, we need a lot more research into this, but we're starting to build up a little bit of a picture. As I said a little bit earlier, it's not so much that there's a hormone imbalance, although sometimes things like that need to be ruled out, making sure there's ruling out things like a premature ovarian insufficiency, premature menopause, or thyroid dysfunction can cause mood changes and they're related to hormones. But there's normally a clear-cut pattern if you've got PMDD or one of the other premenstrual disorders, in that it's cyclical, so it comes like clockwork every month. The symptoms only should really occur in the latter phase of the cycle, and then should start to improve when the period arrives. So if it's not an imbalance or an issue with the hormones, what is it? What we really think is that it is an abnormal response to the normal hormonal fluctuations, or in some cases just an exaggerated response. So maybe with the milder forms of PMS, it may just be being more aware of the physiological processes that are going on, and registering those. In PMDD, though, it definitely seems as though there's an altered function there, an altered response in the brain. And this often is seen when you get this drop off here in estrogen that affects the neurotransmitters in the brain. And it's not uncommon for things to calm down a little bit and improve perhaps a few days into the luteal phase before getting worse again. It also appears to be an issue with the way that some people with PMDD, that the way their brains deal with progesterone, and rather than having that kind of calming effect that some people will experience with progesterone, they feel very irritable, very anxious, and anything but calm. But overall, a lot of it seems to be about this withdrawal of the sex steroid hormone. So this big drop off in the latter part of the luteal phase can be particularly problematic. And for some people, it just seems to be it's the issue to whichever hormone is not really the issue. It's the fact that that big drop off and the changing levels that's predominant. This is a diagram from a paper that was published in an American Psychiatric Journal looking at the etiology of PMDD and what we know so far. So there's little things like there's genetic links there, so we know that certainly some people in this group will have genetic tendency to genetic issues related to estrogen metabolism, serotonin metabolism, that some people cannot metabolize progesterone properly, that there's issues around estrogen, serotonin, and brain-derived neurotrophic factor. These two could partially be related there. And there seems to be a link with a history of trauma, although this doesn't have to be the case for everybody, but there seems to be inflammation seems to play a role, and there seems to be an alteration in the stress response in the HPA and HPG axis. Some studies have shown an alteration in the brain structure and function, but whether this is a cause or if this is an effect of a premenstrual disorder kind of remains to be seen. As Tori says, that PMDD is a cellular genetic malfunction in response to hormone changes, and it should be treated as the serious medical condition it is. How do we diagnose PMDD or one of the other premenstrual disorders? The main thing to do is to track symptoms. So there is no blood test. The only thing blood tests do will rule out other conditions, and this is the only way to do it. So whether you as a clinician, you get your patients just to track at least for 2 months with either a paper chart like this or the DRSP or via online apps, and we're not doing that for at least a couple of months, in seeing a clear pattern is really, really important. This is primarily a clinical diagnosis. So the aims of treatment for PMS and PMDD is really to minimise the hormonal fluctuations. So in more severe cases, say removing the trigger to the menstrual cycle. So that could be by using something like the contraceptive pill, or in say in more severe cases, even going to medical or chemical menopause, or even removing the ovaries if patients are treatment resistant. We want to stabilize estrogen and encourage its proper metabolism. And then we want to alter the brain's response to the hormonal fluctuations, so stabilizing and enhancing neurotransmitters in the receptor response, and also encouraging what we can call hormonal resilience. So this is working on things like the stress response and reducing inflammation and stabilizing the HPA axis. Okay. So you may be wondering, how diet and lifestyle can play a part in something as significant and debilitating as PMDD, and that's what we're going to explore for the rest of the webinar. But it can kind of impact all of these aims here. So yes, it's not going to remove the trigger. It's not going to we're not going to be able to switch off ovulation by dietary and lifestyle measures. But what you can do is it can encourage how people eat and live their life, move, and other things that they may do can help stabilize estrogen and encourage its metabolism. The same, we can have some impact on the brain's response to hormonal fluctuations, and certainly we can have an impact on bodily and systemic inflammation and the stress response. So here in the UK, we've got guidelines which have been developed by the Royal College of Obstetricians and Gynecologists, And these have been kind of picked up and put in probably a more patient-friendly format by NAPS, so the National Association for Premenstrual Syndrome. Essentially, they say the same thing, although there's a little bit more detail in the NAPS one, especially when it comes to the dietary and lifestyle interventions that can be helpful. I know several of you are not from the UK, and on IAPMD have got details of evidence base and guidelines on the website, and it's interesting because I think things are sometimes managed slightly different in the US at least, but obviously this is what I generally work with. So this is the decision-making algorithm we get from the RCOG guidelines. And I'm not going to spend long on this because a lot of this is more than medical management. But if you see, the first line does kind of pay heed to some of the lifestyle things that could potentially impact things. So they do mention exercise. CBT is not a lifestyle intervention, but obviously it's non-medical, and vitamin B6. The other recommendations, things like using the SSRIs, excuse me, and the pill, or using HRT or continuous SRI use before going down to chemical menopause. If we look at the NAPS guidelines, they flesh the lower rung out a little bit more. And what they say here is that severe PMS, which is what PMDD was called for a long time in the UK, they say that it does sometimes improve with treatments from the first two levels, but may require more aggressive forms of management sooner rather than later. So when we're talking about lifestyle and dietary interventions for PMS and PMDD, it's not saying that we need to do this exclusively, and certainly nobody's going to say that if you change your diet or run 3 times a week, that's going to cure PMDD. We don't have a cure for PMDD, but what we can do is help improve things, and this can be an important part of management, and I think it can help patients have a sense of control and realise there are little things that they can do. I mean, there may even be an impact on how well they respond to treatment if they take some of these measures on board. But as you see here, it says at the beginning that the encouragement of lifestyle, improved nutrition, regular exercise, but essentially the focus of diet is on complex carbohydrates and but fibre-rich diet, and minimising processed, fatty, sugary foods, caffeine and alcohol. Stress management is key. Complementary therapies, there is some evidence for agnus castus, and I've never really used St John's wort, but obviously we know there is some evidence for low mood, but I'm not quite sure of the evidence really here for PMDD, but we're not really going to be looking at these. But vitamins and minerals can play a role sometimes in supplementation and sometimes through dietary modification. So there are in the UK, we've got NICE, they've got some clinical guidelines, and they did a review, this is for premenstrual disorders, and these were their recommendations. So frequent, small balanced meals rich in complex carbohydrates. So this is essentially what Katarina Dalton was recommending, like, I don't know, 60, 70 years ago now. Regular exercise, sleep, stress reduction, smoking cessation, alcohol restriction. There's probably no surprises there, because a lot of the stuff is generally what we'd recommend for, to support a healthy body and mind, but it might be helpful to have a little look and think about why they might be helpful in this situation. Now, this has probably gone into a little bit too much detail for some of you, but I've got particular interest in this area, and I just drew this created this little diagram to show how maybe a plant-rich or fibre-rich diet could be helpful in PMS and PMDD, and maybe what's going on. I think a lot of the issue with this is that we don't have a lot of the research. There's evidence that a fibre-rich diet, a plant-based diet, it can be very helpful in PMS in particular, and that's the thing. Most of the research is in PMS rather than PMDD. But I think that most of the recommendations, I can't see how they would be unhelpful for PMDD. When we say a plant-based diet, doesn't need to be exclusively plant-based. So patients don't necessarily need to become vegetarian or vegan, but the focus should be on whole foods and a good intake and a wide variety of different plants. The ways it could help is looking at estrogen metabolism. So this is one way. So in patients who have a plant-rich diet, they're likely to have a reduction in an enzyme called beta-glucuronidase, and this is implicated in estrogen metabolism. So if you have a diet rich, or your patient has a diet rich in meat, dairy products, or processed food, for example, this enzyme is likely to be much higher, and this can reactivate deactivated estrogen in the gut, which can then be reabsorbed and contribute to hormonal fluctuations. And if you've got a hormone sensitive brain, that could potentially be problematic. If you have a plant-based diet, you tend to have a slightly higher SHBG, which is a protein in the blood, which can kind of help moderate the levels of things like estrogen and testosterone, and again can kind of help in terms of stabilizing fluctuations. I've mentioned COMT and DIM pathways. These are important when it comes to estrogen metabolism, and things like vegetables in the brassica family are known to kind of impact these. The gut plays a huge role in mental health. We now know that there's something called the gut-brain axis. So the health of the gut directly impacts the health of the brain. There are 95% of the serotonin receptors are actually in our gut. And although these don't actually cross the blood-brain barrier, they do have an impact on the crosstalk between the brain and the gut. Having a plant-based diet increases your antioxidant intake and decreases inflammatory molecules as well. There's known to be a decrease in arachidonic acid, which is thought to be helpful. So the more plants and more fibre you include in your diet, or you advise your patients to, then you have a more diverse microbiome, which is generally healthier for mental well-being as well. So they will produce short-chain fatty acids and produce prebiotics. These all play a role in serotonin production, and so everything is connected. If you include more phytoestrogens, so things like soya and lentils and chickpeas and things, this can have an impact on one of the isoflavones in that as well, which again is impacted in estrogen receptors. Finally, we've got polyphenols. So these are, a thing we find in plants, and particularly dark berries and things like that. And then we know that they can reduce neuroinflammation. They considered adaptogens, so they can kind of help moderate stress response, and they support the tryptophan pathway, which is a precursor to serotonin. So these are all kind of number of ways that they may have an impact on mental health, which could have a knock-on effect with premenstrual symptoms. There has been some talk about histamine, which is a natural immune signaling protein, and whether this plays a role in PMS and PMDD. We don't really have good evidence, but some people do find benefit from reducing histamine-containing foods in their diet. And we do know that levels do increase just before menstruation. So it's possible that PMS and PMDD symptoms may be partly due to histamine intolerance, but we can't say this definitively. So our bodies naturally produce histamine, and we take it in with our food. But we can't avoid it completely, and we don't want to, we shouldn't need to. But this can if you have a problem, or your patient has a problem with histamine kind of metabolism, that might be having an impact on symptoms, and can lead to kind of an imbalance in the microbiome, and vice versa. And this we sometimes see people having kind of histamine-like reactions if they have an excess of estrogen. So if people are using very high levels of the hormone, or if they just respond in that way to them. So sometimes some of the treatments we're using in PMDD can kind of trigger some of the symptoms, ironically, as well. So sometimes there's a problem with the body clearing histamine, and that can be related to B6 deficiency, or possibly a genetic variation. Okay. But what foods contain histamine? So dairy is particularly rich, processed meats and food, bizarrely avocado. I mean, all foods will contain or at least produce small amounts of histamine when they're ingested, but essentially you want fresh foods. They're the best things to have. It's a really complicated topic, and I'm not an expert when it comes to histamine or low histamine diets. So if somebody believes that's a role, or you think that might be playing a role in your patient's kind of symptoms, so especially if they kind of presenting with kind of allergic type symptoms, it might be good to get somebody, a dietitian involved who can avoid, help advise them. But sometimes we do hear stories that people who go kind of on dairy-free diet or cut out alcohol, that can have a big impact on their symptoms again. And so maybe that's where that comes from. But we don't have enough information at the moment to say, yes, you need to tell all your patients to give up dairy and cut all of these things out of the diet. It does seem that the quality of the diet does have an impact on symptoms here. So there was a randomized controlled trial looking at the vitamin B6 with a broad spectrum kind of multivitamin thing, which contained all of these things here on the left. And interestingly, it showed that both supplements produced benefits in terms of premenstrual symptoms, including PMDD, but the effect was greater with the broad spectrum micronutrient supplement. Unfortunately, this supplement that they trialed we can't get a hold of it. It was just used for that trial, and so there's nothing out there at the moment that actually contains all of these things that were in there. Having said that, this is why it's important to eat a wide variety of plant-based foods again, and made sure that all of these things in the patient's diet are kind of they're included in that. So again, it's just having a wide variety of foods. And I think sometimes maybe the recommendation for a fiber-rich diet is not even so much about what you're cutting out as to what people aren't actually containing in their diet with the standard Western diet. So there's, people worry that if people go vegan or vegetarian, that then, going to miss out on calcium or things like that, but fail to see that people who are having a standard Western diet are often micronutrient deficient because they just don't have enough fibre. I think the average fibre intake in the UK at least is around 18 grams a day. Those on a plant-based diet, it's around 40 grams a day. And the recommendation for health, general well-being is 30 grams a day. So basically everyone could do with increasing their fibre intake. There seems to be a role for glucose metabolism in the brain in PMS and PMDD. And I wonder if this is, again, why say the diets and fibre-rich diet can be helpful in stabilising blood sugar levels. There is this paper that looks at this supplement, which is mainly available in the US, but I have had somebody in the UK who managed to get hold of this and had a good response with this, called Jubilance. And it contains something called oxalacetate, which seems to have an impact on blood glucose metabolism in the brain. But we don't really have much more information about it. More trials are needed, but it was kind of a low risk intervention. The patient that I saw actually had more physical symptoms than PMDD, but she had significant premenstrual nausea to the point that she couldn't go to work. And this really made the biggest difference to her. But interestingly, it's saying that it did improve suicidal ideation symptoms. I'm not quite sure how that would happen, but it's interesting. And I suppose it's minimal risk, other than I don't think it's the cheapest supplement. Okay. Herbs and spices. Again, these aren't going to kind of cure a significant premenstrual disorder, but can be helpful for particular symptoms, and particularly for some of the physical symptoms as well. So cinnamon can help with blood sugar cravings. If people are struggling with cramps and things like that, raspberry leaf tea. You've got fennel, which can help with if there's fluid retention. Turmeric's an anti-inflammatory spice. Ginger can help with things like nausea, and saffron has been shown to kind of help with mental health, especially in premenstrual disorders. There is actually a patented molecule called saffrosund that's available as a supplement, but these are kind of low risk ways that people can kind of have a little bit of control and maybe just have a bit of fun with their diet and add a few things that they may not otherwise do that may actually have a positive impact on some of their symptoms. Okay, so now we come to exercise and stress relief, which is again really fundamental. There are numerous randomized controlled trials actually looking at the role of exercise in managing premenstrual symptoms, and they generally show really positive impact. There was a recent trial in RCT in Istanbul looking at students who struggled with premenstrual symptoms, and showing that 30 minutes 3 times a week significantly reduced the impact on their mental and physical well-being. So, and there was actually I think it was a British Journal of General Practice did a meta-analysis, a systematic review looking at the RCT, and said again that regular exercise has been shown to be beneficial for PMDD and PMS. We're not quite sure the mechanism of action, but we obviously know that it has a positive impact on cortisol. It can help kind of calm down the stress response. It can help release endorphins. There's probably numerous ways that this helps, and obviously it's generally beneficial for everybody's health. There have been randomized controlled trials looking at things like yoga, which seem to have a positive impact on the HPA axis and may decrease the stress response. So again, these are all low risk interventions that could be very helpful and give patients a sense of control. So I think that it's worthwhile recommending them again and supporting them, whether or not they're having medical and psychotherapy intervention as well at the same time. In terms of other things like stress relief, we've got mindfulness, and there have been studies showing that cognitive-based mindfulness therapy has been beneficial in both PMS and PMDD. And again, affecting the kind of the stress response, the HPA axis. And so, I mean, I do recommend sometimes things like the Headspace app or Insight Timer, other things like that a patient can have easy access to. I mean, even just 5 minutes a day can make a big difference. There's also a connection between the sleep-wake cycle, so the circadian rhythm, and the menstrual cycle. So a lot of people will experience this, whether or not that they would consider themselves to have a premenstrual disorder. So a lot of women will find that they don't sleep as well in the luteal phase of their cycle. But for some people, especially those who have PMDD, their sleep may be severely disrupted. What's quite interesting is that there seems to be a connection with seasonal affective disorder, and also with PMDD. And it's thought that there may be disruption with the way the brain produces and metabolizes melatonin in the pineal gland, which is what we kind of need if you're going to get a good night's sleep. And this is why some kind of paying particular attention to sleep-wake cycle and sleep hygiene can be really effective. So in trying to have a regular kind of getting to bed, getting up at the same time every day, ideally the earlier part of the day, getting outside in daylight, using light therapy can be helpful, especially in the winter. And this may be why the fact that some people feel benefit from vitamin D supplementation. I think there's a theory that vitamin D metabolism is affected in patients with significant PMDD, and we know that that plays a part in seasonal affective disorder. So I think all of these things again are connected. We just don't have enough good research to say definitively you must do this, but these are all things that can be really, really helpful. So yes, kind of trying to get on top of sleep hygiene, again, really, really important, but it's the exposure to daylight. And it may be that there may be a role for melatonin in some patients with PMDD, but I haven't seen any good data on that. Okay, and so just finally finishing with a little bit about support. Obviously there's IAPMD in the UK. We've also got the NAPS, as I've mentioned previously, and they tend to deal a little bit more with probably the lesser end of premenstrual disorders, the more mild end, especially if there's more physical symptoms and things like that. So that's a useful resource. And then Vicious Cycle was patient-led. So in summary, premenstrual symptoms affect up to around 40% of the female and AFAB population. And we must remember that, of course, that you say that the trans men and non-binary people can be affected. 1 in 20 meet the diagnostic criteria for the most severe form, which is PMDD. And there are evidence-based treatment guidelines for PMS and PMDD. And patients should always be directed to appropriate support, but hopefully everyone here will do that. That dietary and lifestyle intervention should be recommended to everyone, including those who require medical and surgical intervention. And actually that's something that I think is really important for those patients who've needed to kind of go down that route, because their brains will still be hormone sensitive. And I think anything they can do to kind of have a positive impact on their inflammatory response and things like that, and managing their stress is really vital. Okay. Focusing the diet around plant-based whole foods, essentially rich in fibre. And I often just say to patients to eat the rainbow and eat the alphabet. It's essentially just get as many wide variety of colours and everything into the diet, because where there are colours, that's where the micronutrients are. Minimise and eliminate alcohol. We know that alcohol disrupts the gut microbiota, and we can see how important that was before. Caffeine for some people can really, really trigger worsening anxiety, but it's not the case for everybody. Saturated animal fats do appear to be problematic for some people, and we talked about dairy and processed foods potentially worsening that histamine response. Okay. Smoking cessation is strongly advised if somebody's doing that, because obviously that's it's a toxin, and what we're trying to do is decrease the inflammatory response and stuff here, and that again can have an effect on the gut health as well. And regular exercise, good sleep hygiene and stress management are paramount. And that's it.
Thank you so much. That was so interesting. And if anyone has any questions or any other feedback, you can email professional@iapmd.org, or if you're on the Slack channel, please just do jump in there and ask any questions and become active members of the community, because this is what it's all about, sharing information and learning. So, we can help patients better and improve our knowledge. So thank you everyone so much for coming and being involved. Okay, thank you so much everyone. Take care.